Okay, good morning, everybody, and welcome. Good morning. I am so excited to welcome you all here, and I apologize in advance, or maybe behind, for stopping and interrupting the high school reunion atmosphere that we have going on in here. It is so awesome to see everybody in person. So for those of you who don't know me, I'm Cara Carter. I'm the Senior Vice President for Strategy and Programs at the California Healthcare Foundation. And the last time I was in this room, somebody reminded me, was February of 2020, giving a welcome for a behavioral health briefing much like this, with very little sense of what was about to come. So I could not be more excited to see you all here today for our first in-person briefing since then. So for those of you who don't know us, the California Healthcare Foundation is an independent nonprofit philanthropy, and we work to improve the healthcare system so that all Californians have the care that they need. Our focus is particular on making sure that the system works for Californians who have low incomes and for communities who have traditionally faced the greatest barriers to care. We're headquartered in Oakland. We do have an office here in Sacramento, and we have a number of colleagues that work in Southern California, because our work reaches across the entire state. So today's convening is one of a series of briefings. They are both in-person and virtual that we sponsor for Sacramento policy staff and for others who are interested. These briefings have two core purposes. So they're designed to bring you information that is relevant on key healthcare issues and trends, and also to foster a dialogue on possible solutions to challenges that face our state. So in addition to those of you here in the room, and I will say I'm delighted that there are so many of you, we are welcoming more than 500 people virtually online today that are registered via Zoom. And for folks who can make neither our in-person nor our virtual briefing, we will make a recording of this available for folks to watch on their own time. So today's briefing is about the launch of California's Office of Healthcare Affordability. This year, CHCF's annual health policy survey found that half of all Californians had skipped or delayed care due to cost. And half of those who postponed care said their health suffered as a result. The rates of care that is skipped are higher for people with low incomes. In fact, Californians are more worried about paying unexpected medical bills than we are worried about paying for housing, gas, food, or utilities. To address the affordability crisis, the governor and legislature worked together to create the Office of Healthcare Affordability, or OHCA. It is part of California's Department for Healthcare Access and Information. OHCA is charged with delivering on three key tasks. First, measuring. OHCA will analyze data on healthcare cost drivers. Where are the big increases happening? Second, monitoring. To track the future growth in healthcare costs, OHCA will set targets defining acceptable growth, and it has the authority to enforce these targets. Finally, assess market consolidation, a key driver of healthcare costs. And you're going to hear a lot more details on all three of these from our speakers soon. OHCA is also charged with setting and enforcing targets that are designed to increase primary care and behavioral health investment, promote value-based payment, and help ensure that California has the healthcare workforce to meet the needs of 40 million Californians. We're pleased to bring together today some distinguished speakers to give additional context to the affordability challenges faced by millions of Californians who have low incomes, and to provide an update about the launch of OHCA. We also have a panel of executives that are working within the healthcare system to provide insight into how they are making healthcare more affordable and how they are responding to these challenges. My colleague, Christoph Stremikis, who leads our work on healthcare costs at CHCF, will start the briefing with a few short introductions and an overview. And then he's going to serve as the moderator of a panel discussion as we take a deeper dive into delivering on affordability. There'll be plenty of opportunity for Q&A following the panel. So please join me in welcoming Christoph to the podium. Thanks, Christoph.
Thank you, Cara, and thank you all for being here. It is really a delight to see people actually in person. It was a long couple of years there, so thank you for making the effort to come out. Really great to have all of you here for this important discussion that we've been engaging in California around how to reduce unnecessary cost growth in the delivery system, and transform the delivery system to orient it more towards value. We know that the work of reducing costs and transforming the system is not the responsibility of any one person here in the room. It's not the responsibility of any one organization, one particular industry sector. It's not the purview of any one state office, one department, or one agency. It's a systemic issue that we all need to take ownership of and constructively address together. I am very excited to have the industry leaders here, several industry leaders and policymakers here today to discuss this difficult work that we'll all be engaging in together in the coming months and years. Quick bios for everyone that we'll hear from today. We'll hear first from Elizabeth Landsberg. Elizabeth is the director of the California Department of Healthcare Access and Information, or HCI. She'll give some very brief background about the department and provide some context from her perspective as a leading state policymaker around the challenge of healthcare affordability. Following Elizabeth will be Vishal Pagani. Vishal is the new and inaugural Deputy Director of the Office of Healthcare Affordability, or OHCA. He'll provide an overview of that office, as well as, or including some of the key priorities that he sees for the first several years of implementation. Then I'll return after our HCI policymakers speak to moderate a discussion with several industry leaders who have been kind enough to join us here today. They include Barry Arbuckle. Barry is president and CEO of the Memorial Care Health System. Memorial Care is a nonprofit system of 4 hospitals, 2 medical groups, several imaging centers, and a number of surgical centers located throughout Orange and Los Angeles counties. We also have with us Hector Flores. Dr. Flores is the medical director of Family Care Specialist Medical Group in Los Angeles. For those of you that don't know, Family Care Specialists has more than 300 primary care and specialist physicians serving 30,000 patients with Medi-Cal, Medicare, commercial, or no insurance here in California. And then we're also lucky to be joined by Millie Virgil. Millie is the Senior Vice President of Transformation, Operations, and Customer Experience at Blue Shield of California. Many of you are familiar with Blue Shield. For those of you who are not, they are a nonprofit health plan serving nearly 5 million Californians in the commercial Medicare and Medi-Cal markets. After we hear from our friends at HCI and our friends within industry, we'll have some time for questions from folks here in the room and on Zoom. So please do be thinking of those questions, and we'll have some time at the end to take just as many as we can. But now let me get out of the way and let me welcome our first speaker. Please join me in welcoming Elizabeth Landsberg to the podium. Elizabeth.
Good morning. It is so wonderful, as Cara said, to be in person, to see so many people in person here in the room, and we know there are many, many others of you who are logging in virtually, so we appreciate being together. And I just want to start with a big thanks to the California Healthcare Foundation. It's an honor that you're focusing your first in-person gathering in almost 3 years on the Office of Healthcare Affordability. You're a wonderful partner to HCI, to state government, and to all of us in California with your deep research and commitment to healthcare in California. So thank you for your partnership. So I'm going to talk a little bit today about HCI, just give you a very high-level overview, give you a little bit of context, although Cara already started giving you the context, and we generally don't have to spend a lot of time convincing people that healthcare costs are a problem in California. So I'm mostly going to go pretty quickly and let you hear from Vishal Pagani about the office and our priorities. Yeah, so we covered that. Okay, so the Department of Healthcare Access and Information, or HCI, if you haven't heard of us, hopefully you've heard of OSHPD or OSHPD, but do take note, there's only one way to pronounce HCI. So OSHPD has been around since 1978, and all of the components of OSHPD were subsumed under HCI, but it was time for us to graduate from an office to a department, and we have been taking on a lot of new responsibilities over the last 2 years, so we think that the new name better captures the work that we are doing at HCI. Our mission is to expand equitable access to quality, affordable health care for all Californians through resilient facilities, actionable information, and the health workforce that each community needs. And I just want to go through quickly to talk about the 5 program areas that we work in, just so you know the breadth of what we're working on and some of the synergies there. So on the facility side, HCI is the building department for hospitals and skilled nursing facilities in California. We also set the building standards for clinics. On the financing side, our Cal Mortgage program provides loan insurance for nonprofit healthcare facilities to build or renovate their facilities. Workforce is one of our most critical areas right now. So we know that there is a workforce crisis, healthcare workforce crisis in California, and the state is committed to doing everything that we can to invest in and train racially and linguistically diverse healthcare workforce that California needs, to try to have folks serve in medically underserved areas, and to try to make sure we have providers who are serving the Medi-Cal population. So we are helping train everything from peer support specialists all the way up to doctors and psychiatrists, pipeline to try to bring in more folks to diversify our workforce. So very meaningful area and some good synergies with our Office of Healthcare Affordability. On the data side, any researcher hopefully is very familiar with our OHCA data sets. So we have everything from patient outcome data to financial information about hospitals and skilled nursing facilities, and this will also provide some good synergies and collaboration with the Office of Healthcare Affordability. And then just in the last couple of months, we added this 5th bullet around affordability as we launched the Office of Healthcare Affordability. And also, if you've heard the governor talk about California partnering to manufacture biosimilar insulin products, HCI is also overseeing that work. We know that insulin is unaffordable for diabetics. That's having significant healthcare impacts for those who go without, and so we're excited about that venture. All right, so again, just quickly going through a little bit of context information for you. And I think Cara and I had some overlap, but the bottom line is that healthcare is just unaffordable for most Californians. Healthcare spending per person surpassed $10,000 in 2020. You can see the trajectory. Average annual growth between 1991 and 2020 was almost 5% per year. And that is in contrast to what's happening with wages. So the gray line here is inflation. The yellow line are workers' earnings. And so you can see workers' earnings have kept pace with inflation. Of course, this doesn't account for the past year and the inflation that we've experienced. The orange line are the average family premiums in PPOs, and the blue line are the deductibles. So while wage growth has barely kept pace with inflation, family premiums increased at more than twice that rate, and it's especially striking that deductibles increased almost 4 times as high as wages. So while that shows you what's been going on the PPO side, this is more broadly for employer-based coverage. Deductibles approximately doubled for firms with fewer than 500 employees in just a 12-year period, and for large firms nearly quadrupled over the same period. And then on the right, you can see employer contributions and employee contributions. While both have increased dramatically, I think anyone who has employer-based coverage has seen their deductible go up and their share of the premiums increase significantly. So while what workers and families pay for health coverage and health care has risen dramatically and consistently, there is unfortunately little rationality in the prices of care. So this is just one snapshot example of negotiated prices for joint replacement at various hospitals. And you can see the wide variation between hospitals, and even within one hospital, prices can go as much as quadrupled for the same procedure. This next slide is the important work that Cara talked about that doesn't show up very well in the slide. But half of Californians, as she said, and almost 2/3 of those with lower incomes skipped or delayed at least one kind of health care due to cost in the past 12 months. And it's worsening health care and the results that they're seeing. And then this is my last slide. There is evidence showing that health spending could be reduced without reducing access or undermining quality. So this was a report supported by the California Healthcare Foundation about 2 years ago, looking at where the waste in the healthcare system is. And so you can see these categories. Vishal and I have been on a bit of a speaking tour about the Office of Healthcare Affordability. And, you know, when we talk to those in the healthcare industry, they sometimes push back and say, well, this is, you know, we can't control the cost of labor. That's a fixed cost, or this is a fixed cost. And we understand that some costs are difficult to control. What I really appreciate about the panel that the foundation has put together this morning is to have colleagues from industry, so to be able to hear from a health plan, to be able to hear from a health system, and to be able to hear from a practitioner about ideas that they have for how to both increase quality while reducing costs, I think is very meaningful. So we do know that some costs are difficult to control, and we know that these are costs that we can try to get a better handle on. Vishal is going to talk about the fact that the office is going to focus on investment in primary care, and research has shown that higher spend on prevention and primary care leads to better health outcomes and lower costs. So the office is going to directly tackle that by setting some standards for primary care spend, for behavioral health spend. So we do think there's meaningful action that the office can take. And I'm thrilled to hand over next to Vishal Pagani, who is our inaugural Deputy Director over the Office of Healthcare Affordability. While I've only been working on this the past 2 years, Vishal has been here every step of the way, helping work on the language for the last 3 years. And I would be remiss if I just didn't also note that there are many supporters of the office in the audience, but I need to call out specifically Raz Palmano and Tam Ma, without whom the language would not be what it is, and we wouldn't be sitting here today. So thank you, and hand it over to Vishal.
Thank you, Director Landsberg. So to set the national context, this map shows the number of states that have cost target programs. When California enacted its legislation in July, it joined 9 other states that have gone down this path. One of the benefits of not being the first is that we were able to learn from other states and take the best thinking and craft an approach that's distinctive for its comprehensiveness and also its ability to enforce the cost targets. So this slide looks like it's not showing properly, but if we were to bucket the activities of OHCA, they would be to 1, manage cost growth, 2, monitor system performance, and 3, assess market consolidation. So in terms of the first bucket of managing cost growth, the office will collect, analyze, and report data on total healthcare expenditures. So this is a new acronym that we're going to be using quite a bit, THCE, total healthcare expenditures, which comprises non-claim spending, claim spending, consumer out-of-pocket spending, and then health plan administrative costs and profits. The office will develop a cost target methodology that considers economic factors or economic measures, such as GDP growth, or population-based measures such as demographics. So a cost target tends to be a numeric value of how much the state decides on how much their per capita total healthcare expenditures grow each year. So initially there will be a statewide cost target for calendar year 2025. That cost target is a reporting year only. By March 1st of 2024, the office will publish a proposed target, and the board will have until June 1st of 2024 to approve the target. And these March-June timeframe, that's going to be the same every year to give the industry time to plan for the cost targets. The first enforceable cost target will be for calendar year 2026. And eventually the office will set sector-specific targets, which can include geographic regions, certain types of entities, or fully integrated delivery systems. Kind of the rationale of sector targets is to take a more tailored approach rather than kind of a one numeric value under the statewide cost target. Lastly, there will be a progressive enforcement approach. beginning with technical assistance. This is essentially a conversation between the healthcare entity to find out what happened if they exceeded the cost target. Public testimony at a meeting to understand the drivers of what's causing the healthcare entity to exceed the cost target, requiring the entity to submit a performance improvement plan. And then as a last resort, the office would have the authority to issue financial penalties. So this slide displays the three categories of healthcare entities subject to the cost target. There's payers, providers, and fully integrated delivery systems. The latter category for fully integrated delivery systems, Kaiser Permanente is the only entity that meets that definition. So we do have an all-in approach where all healthcare entities are subject to the cost target, but in terms of data, initial data collection, it'll occur at the payer level. So payers will submit an aggregate data file for total healthcare expenditures. The next bucket of the office's work is monitoring system performance. So, the goal of the office is not to focus on cost alone, but to engage in activities that ensure a balanced approach. So the first would be to track quality, equity, and access. This means we would leverage a subset of existing quality measures that are out there by sibling state departments or other recognized quality improvement programs. The intent isn't to invent a lot of new measures. We think there's a lot of great measures out there that we could pull from to have a balanced story about cost and quality. And then the office would also set benchmarks for primary care and behavioral health spending. So this is to really reorient the healthcare system towards early intervention and health promotion so that more costly specialty care isn't needed in the future. And this will take time over time to implement, but the evidence shows that we could not only deliver better outcomes, but save on costs as well. The next set of activities is going to be on setting goals for the adoption of alternative payment models, or what some may call value-based payments. So the office would set a target and then report on how payers are progressing along that target. And there's frameworks out there, such as the Healthcare Learning Network, Healthcare Learning Action Network, framework with the 4 categories from the continuum of fee-for-service to Category 4 population-based payments. So there's definitely models we could look to for reporting on APM adoption. So, and lastly on this slide, promoting workforce stability. The goal here is to ensure that cost targets are not achieved to the detriment of frontline healthcare workers. It's very important that we have a stable workforce, not only for access, but also care quality. So the office will be monitoring workforce stability. So with the inclusion of these set of activities, the intent is not simply to have a low-cost system, but to take the best ideas out there and reorient the healthcare system towards greater value. So the third prong of the office's work is assessing market consolidation. The office will engage in market oversight activities to partially fill the gap for mergers and acquisitions that are currently not being looked at. So some of you may be familiar that DMHC reviews mergers and acquisitions involving health plans. The Attorney General reviews nonprofit hospitals. So this is really to partially fill the gap in looking at certain transactions. So the office will receive notices of proposed changes in ownership, operations, or governance for healthcare entities. If a transaction is likely to have a significant impact, the office would complete a cost and market impact review. So another acronym, CMIR. So the CMIR effectively assesses whether the transaction would be in the public interest in terms of impact to market competition or affordability for consumers and purchasers. During this process of the CMIR, the office would work closely with other regulators to the extent that there's overlap, and also have the ability to escalate any findings to the Attorney General. I'd also note that OHCA does not have the authority to give a thumbs up or thumbs down on whether the transaction proceeds. Other regulators such as DMHC could place conditions on transactions, but the office's perspective is to increase public transparency for the proposed transaction. So this slide lists the differences between the board and the advisory committee. A few distinctions I'd note are the board is a decision-making board that will set cost targets and approve key benchmarks such as statewide adoption of alternative payment models. The board will also appoint the advisory committee. The board will comprise 4 appointees from the governor and 1 each from the Assembly and the Senate. The Health and Human Services Secretary by statute is a voting member, and the CalPERS Chief Health Director is a non-voting member. So 8 total, 7 voting members. The board cannot have members that receive compensation from healthcare entities except for retirement income. Because it's important for us to get the feedback and input from the industry to make sure that any requirements or data collection is both practical and workable and getting to what we want to get at. There's a separate advisory committee that makes recommendations to the office and to the board. The advisory committee has a wide range of set of stakeholders, including health plans, providers, and consumer advocates. So in terms of key milestones for the next 2 years, OHCA is currently working to build the team. It currently has a staff of 1, which is myself. We hope to make good progress in hiring the leadership team, as well as bringing on expert consultants to quickly stand up the office. In terms of what we have planned for early 2023, we'd like to convene the board in the first quarter, followed by appointing the advisory committee members. And I'd like to note that December of this year, of 2022, we'll be sending out a call for nominations to the advisory committee for consideration by the board. We'd also work on regulation packages for data collection for total healthcare expenditures and regulations for the cost and market impact reviews, and begin some of the work on the primary care investment provisions of the statute. For 2024, we'd set the cost target based on those March, June parameters I mentioned earlier. We'd also begin working to collect some baseline data for calendar year 22 and 2023 for total healthcare expenditures. And then the CMIR program, we'll also begin receiving our first notices of proposed transactions as early as January 1st of 2024. So a lot to come in the next 2 years. So this slide conveys how enforcement could work for calendar year 2026. In the blue box on the right, you'll see there's a stepwise approach to enforcement. It begins with technical assistance and then goes all the way up to financial penalties. As I mentioned earlier, the first enforceable cost target is calendar year 2026. It would need to be proposed in March and then finalized by June. Because time is needed for claims data to settle, the office would not receive the data until a good 6 to 9 months into the following year. So you'll see, 2026 is the first enforcement year, and then we're not going to get the data until sometime in late 2027. So, there is going to be a lag, and we'll also need to allow time for the office to analyze that data and report on performance. So in terms of reporting out to the public, there would be an annual report where performance against the cost target would be reported. So in addition to cost target performance, we'd also include policy recommendations for potential next steps that could be considered by policymakers or public-private entities in the healthcare system in terms of actionable things they could do to contain costs or improve quality. And then lastly, just including this set of resources for those interested in staying up to date with OHCA. We have a landing page on the HCI website. We have a listserv that we use frequently to push out information. And this is where we'll also be posting our board materials. So thank you, and I'll turn it back over to our moderator.
Thank you, Vishal and Elizabeth. That is a very ambitious agenda, and you're a staff of one right now, and I know you have the cavalry coming, so thank you for what you're doing. It is a very ambitious agenda to transform the delivery system and reorient towards value, and I'm just so pleased to have our some industry representatives here today to talk about the work that they've done within their organization. So I would invite the three of you up to the stage for, we'll have about 40 minutes for moderated conversation. And as I mentioned at the outset, we will have some time for questions from those of you in the room as well as on Zoom. So please do be keeping those in mind. Well, let's get started. As Elizabeth and Vishal both mentioned, OHCA is designed to both mitigate underlying cost growth and promote delivery system changes that improve value. Could we maybe each start with you sharing an initiative undertaken in your organization in the past few years that has successfully improved value for your members and patients? And can you be specific about what kinds of measurable cost savings or quality improvements that you found? Maybe we'll start with Barry, if that's all right.
All right, thank you very much. Well, we've had a number over the years that Memorial Care has pursued because we've been really kind of all in on value-based care. One of them that I think we're most proud about is our integration of behavioral health practitioners into our primary care offices. For a bit of history, for those that might not have been around at the time, back in 1999, there was a piece of, I think, very well-intended legislation that I believe had unfortunate unintended consequences. It was the California Mental Health Parity Act, and it had the effect of bifurcating mental health from medical care into really two separate, spheres. And the research is very clear of how powerful behavioral health is in controlling medical costs. So we decided, with a lot of our value-based contracts, to begin embedding behavioral health practitioners, typically LCSWs, into our large primary care offices. And so rather than the old model, which is still the prevailing model today, where a primary care physician suspects a patient might be showing depressive symptoms or anxiety or symptoms of bipolar disorder, they would make a referral to a mental health practitioner. It may or may not need insurance approval. They will get an appointment. They may or may not go to the appointment. I mean, it's just not a model that works well. In our model, the physician hands off directly that day at that moment to a behavioral health practitioner. They then go through their process. We've seen incredible improvement much faster in reducing depressive symptoms, anxiety, bipolar disorder, getting that under management, and the reduction in our medical costs has been over 27% for those patients whose depression, anxiety are well managed. So that's been, I think, a very kind of a win-win outcome. And now we're expanding that. Again, we piloted it with our at-risk, our value-based patients, but we're in a position where we say we can't not do this for everyone, even though we're investing money and someone else in the system is saving the money. But for us in the value-based products, it was made a world of difference.
Great. Thank you, Christoph, and thank everyone for the invitation. So just to provide a little more context on our practice, I'm medical director for family care specialists. We basically have 3 platforms. It's a medical group, and we also have our own IPA, and we run the residency program in family medicine at White Memorial Medical Center. So we're also involved heavily in workforce, and some of the issues that Barry talked about resonate with us. A couple of things about our practice. We're not an FQHC, but we have about 30,000 patients, and 40% are Medi-Cal. And I would say 2/3 of our 30,000 patients live below 200% of the federal poverty level. So even though they're covered by Covered California or may have employment-provided insurance, their families may have no coverage or different types of coverage. So we are what I call a hidden safety net, because we are part of the safety net, but not often recognized as the classic rural health center or FQHC or public hospital. In that context, what's important for us is that over the last 10 years, that the ACA was a shot in the arm for our population. We used to have about 15% of our patients were uninsured, and we were able to enroll them into Medi-Cal expansion and Covered California, and some of the affordable plans that came as a result of the ACA. In terms of transformation and some of the initiatives we embarked upon was the patient-centered medical home model, as well as participating with accountable care organizations. The thing about the hidden safety net is that we're ironically a for-profit practice in an underserved area, and there's many other physicians in that same mold. I would say one of the great triumphs of affirmative action is that Black, Latino, and Southeast Asian physicians are actually doing what they said they would do if they were given a chance to become doctors, as to practice in underserved areas. But nobody taught us what model to adopt, and we adopted private practice. And the reason that's important is that we are really short on capital and short on management expertise to be able to make the transformation that we know we need to make. So for us, the health plans were really key partners in this. Blue Shield, LA Care had a specific initiative on patient-centered medical home that provided us in-kind expertise to be able to make that transformation. Our partnership with Blue Shield also allows us now to implement Epic and the health information technology that we need to be more efficient, to reduce costs, and be able to practice population health with great detail. The other component of this was HealthNet provided us a grant to be able to start educating our physicians in the network of the IPA using the same model that we use for our own practice and the residency program. That grant really helped us to streamline how our IPA performs and to be able to learn from them what other services our patients need, because when they're low income, the social drivers of health really rise to the top. Being a Medi-Cal provider, we're very excited about CalAIM, so we're preparing ourselves for that. And lastly is the integration of behavioral health. Fortunately, family medicine is the single specialty that actually requires residency training to have integrated behavioral health as part of the education. And we've been busy trying to find the resources to help implement that across our entire practice. So we'll comment more on that when we go through further discussion.
Thank you so much, Hector. Millie?
Great. Well, first, I just want to start by what an awesome panel of diverse people you've invited to here. So thank you for doing that and including all of us in this discussion today. This topic is near and dear not only to my heart, but at Blue Shield of California, our mission, or what we like to call our North Star, is creating a healthcare system that's worthy of family and friends, and that means all of our family and friends, and also that it's sustainably affordable. And that last piece of the "and sustainably affordable" really matters at getting this right. So when we talk about specific initiatives that we've taken on, I love that Hector threw me the alley-oop on accountable care organizations, and that has been a really important body of work where we've been able to partner with hospitals, providers, us as the plan, to look at how do we change this model in a way that we can reduce costs and increase quality. And we can do both at the same time. So through our accountable care organizations, we've been able to save over $440 million in partnership with them, looking at how do we advance the changes to get to those kinds of savings. And as a result of that, have been able to keep our premium increases on an annual basis for those members participating in that close to 3%, which, as we saw in the charts, is under what we're seeing at the industry average. So that's on the accountable care organizations. Another one to highlight is around the work we're doing on primary care. And within Blue Shield, we've called it Primary Care Reimagined. But we're also partnering with other plans. So there's 6 of us in total, 5 plus us to get to 6. And we're looking at how do we wrap around primary care providers in a way that we can institute value-based payments. We can take administrative burden off of them, which is a huge burden on our primary care practices, and do that in a way that we are going to get the right outcomes and results. And so, again, an interesting model of multi-payer participation in looking at how we support primary care. And so if there's anyone who wants to join us, let me know. Happy to spend time talking with you about that, as it's a really important initiative for us. And then the last thing I wanted to talk about was just our Blue Shield of California Foundation. This foundation is really focused on whole health. So I think we probably all know 20% of our health is healthcare, 20% is about our genetics, and there's a whole other big 60% that is really about our social and our environment and our behavioral factors. And so our foundation is looking at how do they influence and help change in that space. So think of domestic violence as an example of one of the places where our foundation has spent energy in the past. Foundation has given over $20 million a year on an annual basis towards these causes, and we're up to over $120 million through the life of the foundation. So again, highlighting a few of the things that we're working at the plan level.
That's great. Thank you, Mila. I think
You got one.
my
You snuck
microphone
it.
is
Yeah,
working.
okay, there we go.
I'd like to go back and hear from each of you. Thank you for sharing what you've done within your organizations to transform value. Could you say a few words about how replicable that success may be, or does it serve as a model for others within your specific sector? So I'll start with Millie and then go back down. But Millie, when you're thinking about your ACO contracts, are there special things that Blue Shield is doing that other health plans could do? And don't reveal any trade secrets
Sure.
that get us in trouble.
Yeah, I think the highlight of the ACO or accountable care organizations is the collaboration that it takes to get it done right, and the investment at the plan level to make sure that we're leaning in a way that we are actually impacting and influencing and supporting the changes that the primary care and other physicians are trying to make. And so I do think that it is replicable. It's not easy. It takes hard work. It takes putting your, your energy and your capital where you're trying to drive outcomes and changes. But I do think there is opportunity for others to follow and get success in that same model. I think also, the foundation at large, I think it's a really shining star in how foundations can be established and set up and the impact that they can have on the community at large. So again, put your capital and your resources where your priorities go, I think is part of what the foundation has been able to prove. And that second example around working with other payers, this is a team sport. If we want to get it right, we're going to have to look at how we partner differently across our own industries to come up with ways that we're going to support those that are providing care at arm's length away. So
That's terrific. Thank you. Hector, maybe just thinking either in the PCMH, model that you've talked about, integrating behavioral health into primary care. Are there things there, or are there lessons for other folks, other medical groups?
Yeah, there sure are. Number one, that patient-centered medical home, as some of you may be not familiar with the model, is basically reorganizing healthcare around team-based care, everyone working at the top of their license or the top of their training if they're lay personnel. And so I see my friend Maria Lemos, who runs Visión y Compromiso. Community health workers, promotores, have been great allies for us in terms of the ability to extend our reach to the community, and especially the patients that we're responsible for. The journey to PCMH itself is really valuable. Reorganizing around those coordination of care, looking at implementing technology, including telehealth and remote patient monitoring. Those are really important concepts. Obviously, they take money, and that's really always the challenge in terms of getting to that, replicating that part. The ACOs are really, really useful because they also show a model, including the HMO and the delegated model with IPAs. The ACO shows how health plans, hospitals, and physicians can work in partnership to improve the value proposition for the consumer, for the patients. So I think that these are models that are already existing and replicable. I would add that the most successful ones are physician and clinician-led organizations, clinicians being PAs, nurse practitioners, behavioralists. If you're familiar with the GAO assessment of the initial ACO pilots back in 2004 to 2010, it was the physician-led organizations that really showed the best results. And it's not because I'm a physician, but I'm a student of the issue, is that when you look at the cost items in healthcare, the $4 trillion we spend on healthcare, 40% is spent on hospitals. They are by far the biggest ticket item. 20% is physicians and clinicians, 5% being primary care, 15% being specialty. And this is where the primary care spend is really important, because systems like Kaiser are almost at 16% in their primary care spend when you take the pension and all the benefits that they offer their physicians. But it's the physicians and their clinician allies that control 80% of the healthcare dollars, because nobody gets admitted to a hospital unless a PA, a nurse practitioner, or a physician writes the order. No one gets an expensive treatment unless those clinicians are involved in ordering those tests. And of course, we need the partnership with the hospitals to be able to efficiently utilize their facilities, and also optimally, because we may argue at times that hospitals are too expensive and there's a lot of redundancy. Every sector has redundancy. We just need to be able to identify that. What I learned being on the governing board of White Memorial for 14 years, I learned how difficult it is to run a hospital, particularly a safety net hospital. And they have to have the beds available year-round, whether or not the money's coming in. And so I think one of these models of the ACO and the delegated model really look to supporting the hospitals throughout the whole phase of the services they need to provide. Excuse me.
Thank you, Hector. Barry, maybe is the work that you've done in behavioral health integration, can other systems, learn from that? Is that a model for the broader sector?
As I think about any number of projects we've done to drive down the cost of care, and there have been dozens of them, the answer is how replicable, how generalizable, it depends. In fact, I'm thinking about the slide that Director Landsberg shared on CHCF's work on the waste in healthcare, and we know it's there. We typically, I applaud the research that you all did because it was clearly research-based. A lot of what we see is theoretical or big, broad proclamations with little or no data. In fact, for those that haven't read it, I would put in a plug for the Institute for Healthcare Improvement's $1 trillion checkbook, where they went through an exhaustive research process to actually identify waste, find organizations who had addressed it, looked at how replicable and generalizable it was, and then determined how big of an impact could that make on the U.S. healthcare system. And it was, it generated $1 trillion of savings in the U.S. healthcare system. In terms of some of the initiatives, from my perspective, it really comes down to, from a hospital and health system perspective. Dr. Flores mentioned it's the biggest piece of the healthcare pie. Of course, it's also the one that operates with the lowest margins or negative margins. As you likely know, 51% of hospitals in California are operating chronically in the red. And many more percentage points have unsustainable margins where they can't reinvest in their future. So that's a challenging place to be. And the thought of investing more money in order to have yourself being reimbursed less, which are a lot of the models that exist in driving down costs, only works if you have a rather important piece or significant piece of your revenue stream in risk. One of the alternative payment models, one of the value-based models where you actually benefit from driving down the cost of care rather than it just floating out somewhere in the system and you don't know exactly where it goes. So my answer to your question is, if a health system or a hospital has enough of its revenue coming in one of the many risk-based products, it could be ACOs with downside, it can be contracts with total cost of care responsibility, it can be shared risk, global risk, et cetera, then it makes sense to invest in that infrastructure, because value-based care requires a very different infrastructure than this fee-for-service model, which I think is crippling the U.S. healthcare system.
Thank you for sharing that. I want to shift us all now to look a little bit towards the future. So thank you for sharing some examples of things that you've all done within your organizations that have been successful. When you look to the future, where do you see the real opportunity to continue to improve value within your organization, to reduce cost growth while improving quality? Hector, I think we'll give you the first crack at this one.
Sure. So for us, it's just building on what we've established so far, the patient-centered medical home in particular, and the integration of behavioral health and oral health and public health. Because those of you who practice outside of the public health environment know that if we identify a patient with tuberculosis, we do our part, treat them, screen the family, and then we just hand them over to public health and assume that everything will be taken care of i.e. their coworkers and others who are exposed. We need to integrate much more in that. So it's the mental health and oral health as well. So that's our sort of next big leap. The other part of that is really educating the physician workforce that is in solo and small practices, especially those that serve Medi-Cal patients, educating them on the transformation and where their partners are that are likely to be. So there's a bigger picture that we're trying to address using our curriculum that we were developed with HealthNet. And the other part of that is to some degree consolidation. And you know, I'm torn with, you know, what OHCA's role will be to look at consolidation. And, you know, my friend Cheryl Danberg is always worried about consolidation, always increases costs and never seems to reduce them. We affiliated with Blue Shield through a subsidiary they have called Alteas because we realized we were too small to survive in the marketplace as the consolidation around us with health plans, including Medi-Cal health plans, consolidation with health systems, including those that serve Medi-Cal, and even medical groups. We were a boutique practice for the poor for the last 33 years, but we have to find a partner. We had to find it. That's why we chose Blue Shield, being a nonprofit health plan, with Alteas as its vehicle, because we needed to be able to have a capital partner that could invest in the technology that we need. The Epic EMR is what we're implementing because they are able to write that check that we would never be able to write. That consolidation needs to happen both from access to capital and management, but also the efficiencies that solo and small practices do not have. And we need to be able to help to make that transformation. So there's a bigger picture there as well. And lastly is really recognizing that none of us should look at each other as the enemy, but as potential collaborators and allies. I think that's a real key moving forward.
Thank you. Millie, do you have some thoughts about, you know, where the opportunity is for Shield and maybe the short and medium term?
Sure, and I'm going to piggyback on Hector's comments around collaboration and really the promise that this office has of bringing forward different entities in a way that's different and collaborate to look at how do we get after those cost savings, how do we get after the promise of what value-based payments can bring to us, how do we look at the mergers and acquisitions that are happening in the economic value. So I do think there is you know, this office and the promise of it in combination with the real-time clinical data sharing that just passed recently, that those two things coming together can have real power. And so I think us not seeing each other as enemies, but being a part of that work together and collaborating is absolutely necessary in the near to mid to long term. We'll go all three. I also think within Blue Shield, we have a real opportunity to make sure that the things that we are bringing forward, the solutions, are very member-centered, and that we're making sure that what we're bringing forward is really focused on members. And we like to use this language of high tech and high touch. And so in high tech, it's, are we making things automated and simple and digital, the way we actually operate in most of our life other than healthcare? Are we making and bringing that to our healthcare environment? And so that's the high tech. And then high touch, still personal. Healthcare is still personal. We're dealing with people in some of their most vulnerable times in the healthcare system. And so making sure that equation of high tech and high touch comes together. Also, our members are very diverse. The state of California, we have a really diverse member set we get to serve. And so making sure the solutions on the member-centered side are also going to meet the diversity of needs of the members that we serve. So, you know, in summary, the two things, are we keeping members at the center and the solutioning that we're getting after? Cost and quality can both happen at the same time. And are we also making sure we're collaborating in a different way and leveraging this office and that data sharing to really bring that together as a forcing function?
Great. Let's talk a little bit more about the partnerships in just a minute with other stakeholders, including the office. But Barry, do you have some thoughts about, you know, within memorial care, where do you see the opportunity to improve value? And that's reducing cost growth while improving quality.
You know, I think there are many. Certainly, continued investment in integrating behavioral health with primary care. To me, that's key. Also, continued investment in all forms of virtual care, whether it be telehealth visits, which you know can easily replace an in-person visit in many cases. Virtual urgent care, e-consults. If you're not familiar with that, when you go to your doctor, a primary care doctor, they think you need to consult with a GI physician. The traditional model is they give you a referral. You make an appointment with the GI physician. It may be 2 weeks later. Hopefully, you go to the GI physician, etc. E-consults are such that the primary care doctor connects immediately electronically with the GI physician, transmits your data to them in a safe manner, and the GI physician decides, do I need to see this patient or not? And our data, we keep extraordinary amounts of data on all the things we're doing, shows that in 80% of the cases, an in-person visit with that GI doctor is unnecessary. So it saves that cost of the specialist, it saves the patient having to take off work, et cetera. Another area that I'm surprised I haven't seen as much traction on nationwide, and that is in clinically integrated networks. Now, that phrase means a lot or it means nothing. Everybody says they have a clinically integrated network. When I say clinically integrated network, I'm referring to what's sometimes called a CIN, which is an organization within a health system that is approved by the Office of the Inspector General. By example, in most businesses, if you have employees working for you, engineers or factory workers, and if they can identify a way to reduce costs, many times they can be incentivized. You reward them for driving down costs. Of course, healthcare, you can't. The person that influences most costs that happen within a hospital is a physician, the physician's PIN in the old vernacular, or the EMR. It's a violation of federal law to share the savings with that physician unless you have a CIN. The power we've seen in our health system, in our CIN, driving down the cost across many areas, inpatient, outpatient, multiple disciplines, using the CIN and rewarding the physicians, incentivizing them by sharing with them some of the savings, remarkably powerful.
It's terrific. We just have time for maybe 2 or 3 more questions before we open things up to the audience, but I did want to ask a question specific to the safety net. So Hector, Barry, and Millie, you all have experience in multiple markets. When you think about the value opportunity or the opportunity to improve value over the medium and longer term, specifically within the safety net, maybe we'll start with Hector, you first. Where do you see that opportunity to really drive value?
I think the opportunity is in the movement towards alternative payment models for the safety net. The bane of an FQHC or a rural health center is that they only get paid if they do a face-to-face visit with the patient. Right now, we're all working under public health emergency, which means that they can do telephonic visits and they get the PPS rate that they negotiated. The challenge for them is going to be transforming from volume, which generates the dollars they need to operate, to value, which means that instead of having a patient come in for a prescription refill or a wound check, which a nurse can do, use the clinician's time to do more important work, like a patient with a sore throat also needs a pap smear, and let's go ahead and do it today rather than making her come back for another appointment. That's the value to the patient, truly centered on the patient, but that's not often incentivized in many of the community health centers because volume is what drives the revenue. And that's a constant conflict between the clinicians and administration and the FQHCs that I work with. So helping them make the transition to virtual care, as Barry mentioned, and getting paid for that, to the point that eventually the alternative payment model may be capitation or some variation of that, that allows them then to have the money up front and design the care around what their patients need. But they are going to need help along that transition. And that includes also access to their specialty services. FQHCs do a fantastic job on the primary care side, but the challenge for them is finding specialty physicians who are willing to see a Medi-Cal patient. So that calls a policy change where I think we need to look at our Medi-Cal payments and bring them up at least to Medicare levels so that access to specialty care is facilitated for those clinics. Because part of the value is getting that specialty care. If they have to wait 2 or 3 months to get it, the value drops no matter how hard the primary care clinician in the safety net is trying.
Millie, do you have any thoughts about, within the Medi-Cal line of business at Blue Shield, are the opportunities to improve value there different than what they are in the commercial market?
So no, I think it's echoing on some of the other messages I had around making sure we're collaborating in a way that gets at all of the populations we serve and that we're bringing services forward that meet that diverse population.
Terrific. Barry, any thoughts about, when you think about your Medi-Cal patients, the opportunity to improve value there? Is it the same or is it different then?
I'd make two comments. One, and it's really echoing Dr. Flores mentioned, I think as a state, we really need to address the woefully inadequate Medi-Cal reimbursement. It's a form of health inequity that is just being exaggerated through that. And as we do that, incorporating more of the, you can call them ACO principles or value-based care type of reimbursement structures within the Medi-Cal and or Medicaid or Medi-Cal Advantage or Managed Medi-Cal in the system, I think will help drive some of those things we want to see.
Great. Let's end then our discussion specifically around collaboration, which all three of you have mentioned a number of times. And we're here talking about the new Office of Healthcare Affordability. When you look to that office and the ambitious agenda that they have, what types of collaboration or support are you really looking for to help you achieve this movement towards value, which again is reducing growth and costs while improving quality? Millie, do you want to start?
Sure, I'm happy to. So the answer, do we need to collaborate? I think you've heard us all say yes. That's an absolute must-have in getting this right. And some of the cost trends that you saw at the start, if we're going to curve those trends, we're going to have to all lean in to get that done. As an example, between 2008 and 2018, premiums paid by employees who had employer-based plans went up 49%, almost 50%. It doesn't include since then, so 2018 to today, another 13% on top of that. And you saw wages were flat during that time period. Out-of-pocket costs continue to increase. And the mix that we saw again on employees pay or employers as a portion is actually going up as well. So we're going to absolutely have to collaborate. And I think that there's a really fantastic opportunity within this office to become, in partnership and collaboration, but a forcing function to move us on that curve. If we're going to get, again, to the statistics I quoted, to moving the needle on that, we're going to have to make change together. I also think we've spent a lot of time talking about costs, but the value-based payment piece that's been brought up here will be absolutely important. How we look at mergers and acquisitions and the economic and competitive environment that those create, and the primary care and behavioral health investments, and are we getting to the levels we need to really move the needle will also be important. So we're sort of at a choice point. Are we going to collaborate and figure this out together, or stay on really what is an unsustainable path of cost increase? So those would be my thoughts on yes to collaboration.
Yes to collaboration and support. It's always good to have support. Barry, do you have some specific thoughts around, as this new office is up and running, what type of collaboration and support you're looking for?
Well, I mean, I think the theme collaboration is good, and I am hopeful that during these next several years, while OHCA is, trying to go through the data, and I mean, this is going to be remarkably complicated. You guys know that. Healthcare is so wildly siloed. Expenses move from one sector to another sector and back and within sectors, and it's going to be a difficult challenge. So I'm hopeful that collaboration comes in the office working as we see today with all sectors. And I emphasize all sectors. I appreciate there's a kind of a viewpoint that pharmacy, while it's one of the fastest increasing costs that we're experiencing in hospitals and certainly in the ambulatory sector, is kind of the federal government's problem. I don't believe it is. Just as a side note, we've demonstrated with some of our direct-to-employer contracts, one very large company in Southern California comes to mind, where we have exposure for total cost of care, everything, including the drug spend of all the employees and dependents that have signed up with Memorial Care through this particular arrangement. It was in the first year, we drove their drug cost down 21.5%. And to top it off, they had a PBM in place for the prior 5 years. I don't know what the hell the PBM was doing, but it wasn't driving down costs. So it can be done even on a local level. So involving all parties, the collaborative efforts to try to, make sure that we're measuring things in the right way so this thing can really get traction. And then, and I've said this many times, I'm kind of a broken record on this. I know it's one of the planks of OHCA, but I think we need to spend as much time as we do on figuring out the cost aspects as we are in driving more alternative payment models. To me, those are the solution.
Thank you. Hector, do you have some thoughts as you think about OHCA and the partnership?
Sure. And I think the key will be transparency. There's too many deals getting cut behind closed doors that end up confounding our efforts to really reform our healthcare system and bring value and really have it be truly patient-centered. So transparency is really critical. The second is to look at existing models. I trained at Kaiser Permanente and stayed on as a partner for 5 years before I left to start our group in East Los Angeles. One of the things I learned about their model is that they look at their physician and clinician core as cost centers, and they look at their hospitals as cost centers. So what they're doing is they're budgeting their hospitals to properly serve Kaiser members, but they don't need to have all the bells and whistles that are a ton of wasted money, because not every hospital needs to be the transplant center, not every hospital needs to be the cancer center. And we don't have that kind of collaboration in the non-Kaiser industry. I think we need to look at what they're doing and see what we can emulate. We obviously have different responsibilities. Again, being a white memorial, we take all comers, and that includes a lot of people who are uninsured and covered by Medi-Cal, which I'm glad to see Kaiser making a big move to be a part of that solution, because I think they're uniquely qualified to make that, provide care to that very vulnerable population. But collaboration starts with transparency, looking at models that work and seeing how we can emulate them and tweak them to be able to serve our patients much better. We already have the building blocks. We have health plans and IPAs and delivery networks and hospitals that have common cause. We just need to be able to execute on it. And part of that should be to look at eventually having exclusive relationships so that we get kind of an identity like Kaiser does. When patients or employers buy Kaiser, they're buying a brand, not necessarily an individual doctor. In our world, we tend to specify a specific hospital or specific group of doctors that may not necessarily serve all the patients that sign up with that health plan. And the last thing I think is really staying in tune to patient-centeredness and equity, and looking to them to give us what they need to be able to design what the collaboration should look like.
Thank you so much. Well, we do have about 10 or 15 minutes left before we'll break, and we do want to get out of here at 12:30. I could talk to you guys all afternoon, but we do have other things to do today. There are some folks that are walking around with microphones. If you do have a question here in the room, please raise your hand and they'll come to you. We do also have some questions from folks joining us by Zoom. What we'll do as folks are thinking of their questions is I'm going to transition over there and we'll ask Elizabeth and Vishal to come up on the stage.
Thank you. Christina Oldini from the California Maternal Quality Care Collaborative. I want to thank Dr. Flores, first of all, recognize him for identifying the entire clinical care team, right? Community health workers, PAs, nurse practitioners, and I want to add to that midwives, so thank you. This is for the deputy director and the director. Very proud of our state passing AB 1204, the health equity reporting legislation. Where does that fit? So when you've gone through your segments, is it under monitor system performance? The first report is due to you, OHCA, in 2025. Where do you see the analysis of those hospital equity reports coming in? Where does that fit in terms of value? Because we know care and equity costs money. So where does that fit in the future? Where does that get aligned in the work? How do you see that?
You know, all right, that's another one of our challenges is improving value and, you know.
Thank you very much for the question. So yes, AB 1204 that was signed into law last year, we've done a terrific job. Mike Valley's here and his team has stood up a hospital equity measures committee and we will have measures and reporting. So I think, as Vishal said, it's critical that we measure equity and quality at the same time that we are measuring costs so that we drive toward that high value system that we need. We don't want to reinvent the wheel on those equity and quality measures. So DMHC is doing incredible work around equity and quality measures. DHCS is, CalPERS is, Covered California is. This is another example specifically on the hospital sector. So we will be adopting a subset of those measures as we do our to be parallel work as we're looking at cost growth, and we'll certainly be looking at those hospital measures and what subset of those should we specifically be measuring as we're looking at the cost growth. Thank you.
Yeah, Crystal?
Thank you. Is this working?
Yes.
Okay. Thank you so much, Maria Kalina, California Collaborative for Long-Term Services and Supports. And this might be a little bit of a left field question, but I'm wondering if anyone can speak to how much focus or consideration is being given to home and community-based services or long-term services and supports in context of this conversation and just affordability overall, particularly as CalAIM rolls out more broadly to older adults and people with disabilities next year with enhanced care management and community supports. Would love to hear your thoughts.
Yeah, it's a great question, and I think the answer is that some of it is still to be determined. As Vishal said, we'll be working with the board to determine the methodology on total healthcare expenditures. We will be capturing, we anticipate we'll be capturing all the Medi-Cal costs, so to the extent Medi-Cal is covering long-term supports and services, that will be captured in total healthcare expenditures. Private patient pay for those services won't be captured, but I think it is certainly an important cost savings to have more home and community-based services and have the services provided in that measure. So anything you want to add, Vishal? Okay.
Maybe we'll go to one of the questions that came in on Zoom is we've been talking about how to control, underlying system costs and spending and improving value there. Maybe this is a question that starts with the folks from HCI and then maybe goes to anyone from the industry that wants to answer. But how do you expect these efforts, or what type of impact do you expect these efforts are going to have specifically on patient out-of-pocket costs and affordability? Vishal or Elizabeth, do you have thoughts?
So the office, total healthcare expenditures is going to be about kind of what was spent on healthcare, and then there's premiums, which are kind of based on an actuarial science on kind of what they project. They're going to, the premiums, what the health plan expects to spend, and it's tied to that. But eventually, over time, as the cost target is data is collected on what was actually spent on healthcare, we'd want it to translate into lower premiums over time. It's not going to be a one-for-one, because of the data lag. With the way our data is going to come in, almost 9 months after the year closes. But eventually, over time, we want to be able to show that story that premiums, are going down because of the office's work. If healthcare entities are successful in meeting the cost targets. Another thing is part of the THCE definition, total healthcare expenditures, there's one component for consumer out-of-pocket costs. So that's going to be an important metric we want to monitor over time, that we'd want to make sure that healthcare entities are meeting the overall target, and we wouldn't want that particular category to grow beyond the cost target, or be out of whack with the overall performance. So we are going to be paying particular attention to the consumer out-of-pocket spending that households experience.
Completely agree with all that Vishal said. I mean, that is the impetus for this office, right? I mean, Californians are paying too much for healthcare, and so the total healthcare expenditure costs will include out-of-pocket payments. Now, it won't, if I am paying privately on the side for acupuncture because I didn't want to go through getting my plan to cover it, that won't be captured. But anything in terms of deductible and copays for covered benefits with health plans will be covered, and it's very important. I mean, the graphs we showed earlier, and again, we've all experienced it, show higher deductibles, higher pushing off of the cost to consumers. And so definitely one of the primary focuses of the office is to try to lead us in the other direction.
Yep. Anyone from the industry, maybe, of the affordability or the value work that you've done, are you able to track that? And any advice, as this system-wide cost containment work is done, how do you return those savings to consumers?
Sure. And I'll start with the fact that our medical group is also an employer. We have 175 employees, including our clinicians. And we've always, our goal is to buy the same product for clinicians and frontline workers, because it has to be equity there. And the design, the benefit design is to minimize the out-of-pocket costs for our employees, which reaps dividends because we've had great longevity and retention of our employees. So there's doing the right thing also is the smart thing. And I think what we need to do is engage employers as purchasers, along with CMS and DHCS, to take that same approach to minimize the out-of-pocket costs, because it's really slamming our upper middle income families. I have patients who come to me and say, you worked on that ACA, it's your fault that I'm paying more, because they say the ACA didn't do anything for them, because their employer switched from HMO to a PPO product where the employer has a defined contribution and any increases come off the shoulders of the worker and their family. So we need to have a conversation with the purchasers. And I know PBGH, thanks to Elizabeth McNeil being active in this, is looking at this, CalPERS certainly. I think we need to have a discussion about how we start transferring the savings that Barry was talking about and not punish the ones who generate the savings, but also share those savings with the employees who are carrying that big burden.
Just a comment. I know an increasing number of hospitals are putting these kinds of programs in place, but a number of years ago, Memorial Care put in what we call a patient concierge program, where 100% of any elective procedure or test at any of our facilities, someone calls the patient to walk through what their responsibility is. And we have had a number of cases where they were referred to us, but we're not in their network. And so we'll explain to them, do you understand that's a situation? Here's where you go if you would like that procedure. Here's what it'll cost if you come to our facility. And the number of thank yous and kudos we've received from folks that said, I had no idea. I can't figure out this morass of how much I owe where and these high deductible plans. So we've made it a very concerted effort to make sure the patient is informed in what their responsibility is based upon what plan or product they have.
Yeah, and I would just add, I don't think we actually get to affordability if it isn't landing in change in the way that our California counterparts are seeing healthcare. So if we're getting cheaper costs in other areas amongst ourselves, and that isn't translating into a way that it's less expensive for Californians, then we aren't doing our job either in this office or us as plans and health providers in the state. So I think it absolutely has to land there.
Thank you so much. We just have time for 2 more questions, and we've got one in the room here, and then we'll get one from Zoom. I would like to remind everyone here in the room, there is a evaluation form that's in your packet. We really do look at those closely, so please do take the time to fill those out. Now, our question here.
So, good afternoon. I'm Nina Weiler-Harwell with AARP California. So my question is really about the consumer experience. What will the consumer role be in terms of informing, advising? I know there's going to be an advisory committee, but even beyond that, the work that you all are doing. And also, will there be measures beyond the quantitative, in other words, qualitative interviewing or surveys of consumers in terms of seeing their costs ultimately go down?
Yeah, thank you for the question. And absolutely, we want to have consumer voices, consumer advocates, consumers themselves involved at every step. So there are a lot of opportunities for engagement. The board meetings and the advisory committee meetings are subject to the Bagley-Keene Open Meeting Act. We hope we will have very vigorous participation by all of you and others involved. We absolutely need to hear from you and to hear from consumer voices. So we'll be workshopping a lot of these methodologies, workshopping the regulations. So please do sign up for our listservs. We want to hear all voices. So there will be specific consumer representation on the advisory committee, but we also want to hear from you at the meetings and in a variety of ways. Obviously, we'll take written testimony and the like. And to the point about whether we'll have qualitative as well as quantitative measures, I think it's an excellent point. I mean, certainly as we've been working on the hospital equity measures, for example, we're looking at some consumer patient survey information as well as some of the exact patient quantitative information.
So let's end with a question in one of my favorite areas, which is data. And this question comes from Zoom, and someone is asking specifically around the data that OHCA is going to have available. So maybe, Vishal, you can take this, or Elizabeth. Can you just remind folks what data will you have access to? Data from payers, data from the state all-payer claims database. We have access to any clinical data. Just maybe remind everyone what you will have access to. And then I'd like to go to our industry panel and ask a follow-up about the data that they need to improve value. Vishal or Elizabeth, do you want to?
So I'll start. So the office will be collecting new aggregate data from payers about total healthcare expenditures. OHCA is building the new all-payer claims database, our healthcare payments data program. And just to draw a distinction, and then I'll let Vishal talk more about additional data that the office will have access to. So again, the total healthcare expenditure data will be aggregate data. We'll need to do a lot of design work to decide what exactly goes into that. We'll be getting that data from payers. It'll be aggregate data broken down by categories, and again, we'll have input as to what those categories should be. And then as we build the all-payer claims database, which has granular claims level and encounter level data, and we have billions of records already that as we get 3 years of historical data, as OHCA identifies cost drivers that we want to do a deeper dive on, that's where we'll look to the healthcare payments data program and the granular data there to do that deeper dive. So there'll be a parallel and back to collaboration and synergy, some very important synergy with our healthcare payments data program. But Vishal, do you want to talk about other data that OHCA will have access to?
Yeah, that was a great summary. Kind of the gist of that is like OHCA is going to get the top line data, but then the claims data is where you do that deeper dive on drivers. In addition to the cost data, we're going to be getting data from our sibling departments on quality measures to the extent that to reduce burden on payers and providers that currently report. APM data collection is going to be a new data submission, so we're going to have to workshop and design the specs for that. The same for primary care and behavioral health investment. Primary care, there's already been a lot of great work done by CHCF has commissioned some of the work as well. So we do think we have a leg up in that area. But in addition to the cost, the non-cost aspects of the office are also going to be new data assets for the office.
Maybe we'll end then with the industry panel. If you have just maybe a minute or two on what data you have when you're trying to transform value within your organizations. Do you have what you need? Are there other elements that you think that are going to be required as you do this work going forward? And just a minute or two from each of you if you have it.
Absolutely. Yeah, it's really universal information from all payer classes because it's so complex to begin with. And so we need, to the extent OHCA can really streamline the movement towards health information exchange platforms that we can actually track all of that. And that would include consumer information. The MHC has the CAP survey. The Department of Insurance oversees the PPO world. I think we need to have a similar thing and add questions that relate to out-of-pocket expenses and affordability for the consumer.
From a provider perspective, our best and most robust data are in our value-based plans, our risk-based plans. That's where we have access to all the data we need to make the decisions to drive down cost. From the kind of the global OHCA perspective, I'm hopeful that you'll also be able to access data to identify across all sectors entities that have dedicated themselves to driving down costs. And they exist in all entities versus those that haven't done as much yet. Because if we just set a benchmark based upon some prior year without consideration of that, and then put cost escalations on top of that, we're baking in an unlevel playing field that exists today.
Okay. Millie, we'll give you the last word.
Sure. I mentioned data earlier, and the data sharing around that real-time clinical data is absolutely critical for us to be able to see what's going on in the various members and where are they going and what are the experiences are they having and how then do we help them manage their care better. So not exactly related to the cost drive data, but I think the mandate around real-time clinical data sharing is an absolute must for us to change the experience and outcomes.
So with that, let me end with two reminders and one request. The first reminder is there is a survey that's in your packet and it's available online. And again, we really do look at those, so please do provide your candid thoughts about this event and our future programming. The second reminder, for those of you that are here in the room, there is lunch in the back. Please do take it with you on your way out. And then the third thing is a request. Please join me in thanking all of our wonderful panelists today. Thank you all so much.